Moving into this morning session, it really gives me a lot of satisfaction and happiness to introduce Dr. Vicki Young, who is the Director of Operations with the South Carolina Primary Healthcare Organization. So just to clarify, in the United States, the National Association of Community Health Centers, from which you heard yesterday via Dan Hawkins, is our sister organization or cousin organization in the United States. Because there is such a large number of community health centers throughout the United States, a critical mass in all states and U.S. territories, there are also state-level organizations. And so typically, those organizations are called PCAs, Primary Care Associations. They do represent community health centers within their respective states. And so that's the organization that Vicki spends her days helping to run in her spare time, which I imagine is little. Vicki is also a national research collaborator with the U.S. National Association of Community Health Centers. And through our partnership with NAC, as they're called for short, we've really been able to build a relationship and hold a number of conversations around areas of common interest. One of a key among those really being research. So how do we leverage what they've done? How do we build on what they've done and share what we're doing around not only national level community health center research agenda, but working to help community health centers build in-house research capacity. And so that's the work that Jennifer Rayner and our research working group are carrying forward. And there's lots more to hear on that. And so we thought this is a fabulous opportunity, given that we need to move in this direction, and building on many of the conversations that took place about being able to build the evidence base for community health centers, not only at the macro level, but from the ground with community ownership and support from individual community health centers, the perfect opportunity to have a research leader from the United States come up and share some thoughts on the evolution of that movement in the United States, where community health centers have gone. And I think, not to steal too much thunder, but speaking about the state versus national, not versus, in combination with the national level, and how that moving that research agenda has enabled community health centers throughout the United States to advance the policy agenda around community-based primary health care. So I will shut up, and it gives me great pleasure to welcome up Dr. Vicki Young. Thanks, Vicki.
Well, I'd first like to say thank you to both the Canadian Association for Community Health Centers and our national association, the National Association for Community Health Centers, for getting me here. Actually, Michelle Proser, the Director of Research at the National Association of Community Health Centers, was initially going to be here. Scott reached out to her, and for some reason she could not be with you, and I know she wished she could. And so I got a call one day, and Michelle said, "Vicki." I said, "What, Michelle?" She said, now normally it's me doing the opposite. It's normally me saying, "Michelle," and she's saying, "What, Vicki?" So when she explained it, I knew I could not say no, but the more I started thinking about it, and the more I talked with Scott and Jennifer and others, I saw it as an excellent opportunity to learn what you're doing here. So I don't see this as you learn what we're doing. I see this as bi-directional. And so this has been a wonderful experience for me. And I thank all of you for being so open and friendly and inviting. And the other day at the tour, almost making me a honorary Canadian. So I do appreciate that, because I have learned a lot, and my thirst for learning more has been advanced. So I thank you for that. I was looking at the tweets, and I started feeling like a little bit of a rock star, and I can't sing either, Scott. So I hope that what I have to share with you doesn't disappoint you, because I kind of feel like, oh, wow, the buildup. But I do want it to be a conversation, and I said that to Scott. I'm hoping that this fits in with your conversation. I hope that what I've prepared for you to share with you is just the start, just an impetus for us to continue the dialogue and the conversation, for going back and forth around what do we do, because many of the things that you are experiencing and that I've heard you experience, I don't know if some of you that have allowed me to kind of eavesdrop on your conversations have noticed my head going like this, or last night, I think with Jack, Dan kept pointing to me going, does that sound familiar? Does that sound familiar? And it does. So it shows that we really are kindred in this movement and what is going on. So now I will start. The way that I'd like to lay this out is just to share with you what our story has been in the United States and give some background. And where we are now and where we're headed is what I'd like to do. And then talk a little bit about our parallel stories. Because again, I am so glad I got to come in earlier and actually be a part of the conference, because our stories really are truly parallel stories. And so talk a little bit about that. So our movement, the Community Health Center movement in the United States, and Dan Hawkins mentioned some of this yesterday. I don't know if you recall from his presentation, but it started from a couple of physicians, or a physician and one of his colleagues, watching and observing what was going on in South Africa, and the model that Dr. Sidney Clark had created in South Africa for the Community Health Center of, by, and for the people. Well, in 1964, after observing this, Dr. Jack Geiger and Count Gibson brought it back to the United States. And when they brought it back to the United States, as those of you who are historians know, this was a very contentious and tumultuous time in the United States. It was right in the midst of the war on poverty, the civil rights movement, and many other social issues. And initially, it was funded as a pilot through the Office of Economic Opportunity. So some might wonder, healthcare, why that office? It was because this model was a very comprehensive model that did not focus just on the provision of health services, but holistic approach to meeting people where they are and providing them with what they needed. And included, I think, beyond, and I think this is key, actually is part of the excerpt of the grant that they wrote to get the funding, this pilot funding through the Office of Economic Opportunity, was the fact that they were going to affect and look at economic, educational, and environmental issues that affect health as well. And I do apologize, it looks like some of the slides, the points, and we'll fix that so that you'll have that when it gets back to Scott to send out, that some of it has bled over, so I do apologize for that. The first two community health centers in the United States, one was in Massachusetts and the other in Mississippi. Can you imagine two very, very different populations? For those of you who are familiar with the United States, they are very different, demographically, geographically, every way different. But they still had similar needs. They still needed health care for the persons living in their communities, and addressing other needs, not just health care. But they realized that they had a wonderful opportunity as they provided the health care to service and take care of those other needs. And the focus for these two health centers was on stimulating change in the family and also the community knowledge and behaviors. And we all know how hard it is to impact behaviors at the individual level. But that was a focus of theirs. So it wasn't just on preventing disease, and it wasn't just on the appropriate use of medical services, but those other things as well. So you could say that there was a twofold purpose for these community health centers. And the twofold purpose was to be agents of care and also agents of change. So yes, we're going to take care of your health needs, but we also want to be agents of change within the communities and improving the communities. So 3 elements arose from these two men coming together with the assistance of others to develop this model and to actually put forth the grant to the federal government for this particular model. And the 3 elements are that they're going to provide community health services, community participation, and community economic development. And that still is the tenet for community health centers in the United States. It is key that we represent and move forward the position that we are small businesses within our communities. So we are an economic engine within our communities. Sometimes in smaller communities, we may be the largest employer. And then when you think about the things that we purchase, we keep the economy in some ways or contribute to the economy, especially in the smaller communities. So the economic development is key. And then the community participation. I'll talk a little more about our federal requirements and the federal law that came from this initial pilot, this demonstration pilot, how it speaks to how that community participation has to be a part of what we do as community health centers. But before I do that, just a quote. The test of our progress is not whether we add more to the abundance of those who have much, but is whether we provide enough to those who have too little. And that is something that the founders of our movement in the United States held very dear, and we still hold very dear. Now, sometimes, when you have to focus on whether you're going to be able to provide this service for that patient, sometimes you get a little lost in that. But we still come back to this actual quote, and it is a part of the fabric of who we are. So, our federal requirements. When it got to the point that we were able to advocate for and actually have a provision within law that actually describes who we are as community health centers. So I think that's a difference from our system and your system, is that it actually describes who we are. So we have a general definition of who community health centers are and certain requirements that they have to fulfill to keep what funding they do receive from the federal government. So very generally, those federal requirements are that they have to be a nonprofit organization that has to be accessible to all. And they go further in describing how that accessibility is. It may be hours. There are different ways that you have to be accessible. And one of the criteria for accessibility is also affordability. Community governance representative of the health center patients. And actually 51% of the boards of each of those nonprofit organizations, the community health centers, and they have to have boards, 51% has to be made up of patients. And that's not a loose definition, because someone asked the other day, what is the definition of a patient? I said, well, I can tell you what it's not. It's not someone who came in to get their flu shot and you never see them again. You want to make sure that you are actually providing care for these patients, or you are offering the opportunity for them to come in. Now, we know because of behavior sometimes they don't always come in when we need them to come in, so we have to be there and support them to try to come in when they need to, but you have to make sure that your patients that are a part of your governing board are your true patients. Comprehensive patient and community-centered care across the life cycles. So one of the terms that is used is from cradle to grave, or cradle to death. So we offer those services. It may not be at every site, but each organization has to offer services that are representative of the life cycle. And also it has to be comprehensive. So this is where the enabling services, as we call them, and I'll say a caveat right now. I think I was talking to someone earlier. I think that because of the funding, sometimes we have veered away from some of our enabling services. We try to provide what we can for the community based on their needs. There are certain things that have to be there, like transportation, linguistic services, and other enabling services have to be there. But there are some that we may not be able to afford right now because of funding to provide the way we'd like to provide them. But we are still keeping a focus on the fact that people cannot seek care if they have other issues that they're dealing with. And we have to address those issues when they come in to the door. When we meet them where they are, we have to address those issues as best we can. So we're still fighting that fight, too, around the social determinants of health and making sure we refocus our prioritization on that. Broad definition of health. So it does include more than medical care. We're talking about oral health, behavioral health, and for when I say behavioral health, I'm meaning mental and substance abuse as the broad definition of behavioral health. Located in federally designated medically underserved areas or serving medically underserved populations. And that might hit some of, I think someone mentioned the other day, priority populations or special populations. We use the term a lot. And it has to also be in an area that is medically underserved. And there is a whole calculation for how the government decides that it is a medically underserved area and takes into quite a few factors. And there has to be an ongoing needs assessment and quality improvement plan. So, and I heard some discussions around needs assessment. I think someone asking on the tour, I believe, well, how often do you do your needs assessment? And these same questions are being posed in the U.S. of community health centers there with, well, how are you doing it? Which instrument are you using? Are you working with your community partners to do that? So they do have to periodically have a needs assessment, and it has to be recorded and documented as part of their requirements to report back to the federal government to show that they have met this. And quality improvement plans have to be on file, and they have to be monitored, and the project officers, because each community health center has a project officer who is employed by the Bureau of Primary Health Care, which is the funding source for community health centers. So they have to periodically report on that. Speaking of the Bureau of Primary Health Care, or BIPIC, you'll see the acronym throughout the rest of the presentation. They require, so looking at those federal requirements that I just discussed, the Bureau had to determine how are we going to assess or operationalize those federal requirements to make sure that as we are agents of oversight, that is the Bureau, how will they ensure that centers are actually fulfilling those requirements? And so they came up with the 19 key health center program requirements. And incidentally, centers would have a review periodically. And how often that review occurs has changed over time. But currently, in the environment that we're in now, there is much scrutiny. In fact, those reviews, yes, a lot of scrutiny. Yeah. So those reviews are coming more often. And they literally send in a team of maybe 3 persons to come in and actually stay on site for like 3 days and work with the staff and the administration of the community health centers and go through those 19 key requirements and say whether you've met them or you haven't met them, and recommendations for how you should meet them in the future, and then some also performance improvements. So even if you've met them, if they have an idea of how you can do a better job, that QI piece, then they share that with the centers as well. And the 4 categories that are covered within those 19 requirements are need, so that's where that needs assessment comes in. Services. Are they adequate services that are being provided? Do you have the staffing to provide those services? Are you meeting your target? Because within the grants that the community health centers have to submit, they have to say what their, I guess, baseline is for the patients, number of patients they'll serve, the services they will provide. And so the reviewers come in and actually look at that. And then there's management and finance. Each of the community health centers has to go through an audit annually. And they have to show certain management processes and finance processes are in place. They also have to show that they have a sliding fee scale because, you know, a few slides back I mentioned accessibility. And I think I said something about affordability being a part of accessibility. It's not the only part, but it is a part of accessibility. The affordability piece for community health centers is that they have to provide a sliding scale or a discount scale for individuals. Once they are deemed to be able to provide or support their care at a certain level based on our federal poverty levels, then each organization has a scale that they will discount at a certain level depending on the individual's ability to pay. And then governance. And so that goes back to whether you have the community representation or the patient's representation on your board, whether you have a diverse board. And it's not just enough to say that you have patient representation, but are you representing the demographic makeup of your patient population, so that every population that you serve has a voice. And so that's why that has to be there. So that's just our background, the movement in and of itself. So where are we now? And through these next couple of slides, I'll share a little information that might parallel some of the information that you received yesterday with Jennifer. And then moving forward, you may also get some of the information like you did with the survey. I'm trying to parallel that because we actually did do a national survey as well. And we also have the information on our centers. So community health center funding sources. They receive funding from public insurance, our Medicaid, Medicare. In fact, it's cost-based reimbursement for Medicaid and Medicare. Private insurance, which probably makes up the smallest percentage of our patient mix, as far as the payer mix, is private insurance. And then federal grants from the Department of Health and Human Services, Health Resources and Services Administration, and the Bureau of Primary Care. So not only do they receive dollars from their actual grant so that they have to meet those 19 requirements, those dollars to provide services for those who are uninsured or underinsured, but they also may receive other types of grants, like for our HIV/AIDS population, they may receive a Ryan White grant. And there are other opportunities. Through our substance abuse department, they may receive grants to provide services for substance abuse service provisions. So there may be other federal grants that they can apply for. And then patient fees, and that's where that sliding fee comes in. They have to have that discounted fee for persons who are between 100% of federal poverty level and 200% of federal poverty level. Those above 200% of federal poverty level, then the center can charge whatever their full charge is. And then the discount comes for those who are below 200% of federal poverty level. And below 100%, the organization has the flexibility of maybe, they don't have to, but maybe assessing a nominal fee for services. And that nominal fee, though, you have to ensure that is not a barrier to them receiving their care. So that's really tricky for community health centers to assess that within their communities. What is that? You know, if everybody else is paying a copay of $25, in my population, can they afford that? If they can't, then I need to make sure that I am assessing it, placing it at a certain level. But on the flip side of that, because the federal dollars do not pay for all of the care, as a business staying viable, they have to look at what they can afford to give up, if you will. So that's a tricky balance for community health centers, but most of them err on the side of the patient and making sure that they can get in and be seen and look at other ways to fund the services that they provide. So our 2012 demographics, and Dan mentioned some of this yesterday as well. We have close to 2,000 community health center grantees, and I purposely said grantees because if you go to the section of the federal law that describes health centers, they include community health centers, healthcare for the homeless centers, migrant health centers, public housing centers, and others. So they're spelled out there. So the near 2,000 is all of those different types of health centers. And those 2,000 or near 2,000 health centers actually served over 21 million patients in 2012. Of those that they served, 92 or close to about 93% of the patients were less than or equal to 200% of poverty, and 71.9 or 72% were actually less than 100% of poverty. So that gives you a little idea of our patient population. 36% are uninsured. close to 41% are Medicaid recipients, and 8% are Medicare. Now, that's a growing number for us. Our populations are aging, so we're seeing more seniors being seen at our community health centers. Yes. Okay, 200% of poverty. We have set federal poverty levels in the United States. So it says if you have and I don't know the exact numbers, but if you have a family of 4 or an individual who makes a certain amount, then it places you in certain levels of the federal poverty level. So, of course, 100% of federal poverty means you are poorer than someone who is 200% of federal poverty. And but basically, they're in poverty. If you're less 200% of the federal poverty level and below, then there are people who need assistance. And you Medicaid and Medicare. Medicare is the public insurance for persons who are senior citizens. So it's different from your Medicare in a lot of respects. And then Medicaid is for basically children and families with children who are in poverty, and it's again based on the federal poverty level as far as how they're served. And it also is up to the states what level they will provide services for. So a state may say, I will take children up to 133% of federal poverty, or 200, or 300, or 400% of federal poverty. It depends on what they decide they want to do and how many persons they feel they can provide that support for. So it is actually for children and those who have certain conditions that make them their income bracket, and also because of their condition, they are unable to access services or get private insurance on their own. So again, it's helping those who are in need because of their federal poverty level they're impoverished or need services. And then for the Medicare, it is for seniors or the elderly. And then as it relates to our grantees, 13.9% are special populations. And I mentioned some of those special populations in that we actually have grants within the health services program, health center program for the homeless, the public housing, migrant, and seasonal farm workers. We also have grants for school-based clinics, so that the community health center can be either set up at a school, near a school, and then working with a school to provide services. And then also a newer emphasis has been on veterans. With the current administration, there's been a real emphasis on providing services to veterans. So another break now with another quote. We are only as strong as we are united. We are only as strong as we are united, as weak as we are divided. And you can tell I'm a Harry Potter fan there. But I wanted to put that one in here because it speaks to the fact that we all have to work together. And we are only as strong as, another way of saying it is the weakest link. So we have to make sure that we work together so that we can provide the services that our communities need. And when I say weakest link, I'm not talking about the patients at this point. I'm talking about how we as community health centers work together to provide services, how we share information, and how we work together to share best practices so that we can all be providing the level of care that we want to the persons who live within our communities. So, how did we get to where we are, especially as it relates to research and the use of data and also making the case to our policymakers so that we could receive the funding that we have, the different grants that I mentioned and the funding that community health centers receive to provide care for the uninsured and the underinsured? Well, we definitely had an advocacy strategy. And Dan Hawkins, Tom Van Coverden, and the whole federal affairs staff at our National Association have always been at the forefront of devising the strategy, the advocacy strategy on a national level. And then, of course, on the state level, strategies have to be developed as well because, as I mentioned to you, our Medicare, the public insurance, Medicare is actually administered at the state level. So you may have state differences, so you have to have a plan there. But nationally, we also work with one another who are at the state level to share best practices on how we work with our state governments around some of these issues. But definitely an advocacy strategy, and also ensuring that our centers continue to provide quality, comprehensive care. So what did we do initially as a part of that strategy? Well, qualitative data and evidence has always been important. It is always important to tell your story. There is something about the visceral response to someone who is sitting down with the legislator telling their story about how they might not have made it had they not been able to go into a community health center and receive services. So that's always going to be important, to tell your story in a qualitative way. But we also recognized early on, as time went on, that quantitatively it was going to be important too. Because people started saying, that's important, but I also have this other organization over here who's giving me this very similar and compelling qualitative, story. So how am I to decide when I have to look at funding and how we divide up that piece of dollars that we're going to be able to give to funding to programs like this? How do I decide who to give it to? So we realized that we're going to need some data, some quantitative numbers to prove some things, to prove that we are actually accessible to patients and that they're able to receive services and receive quality services. How are we quantifying that? And also the fact that we're cost effective. And so those were our approaches early on. And different parties, well, let me say this, different individuals wanted different information. There's some who wanted to hear more about the accessibility. So where's your data showing that you're accessible? There are others who want the data around cost effectiveness. Show me how you're costing us less. And so we had to prepare both sides or different sides to be able to convince them. And successfully, we were able to do that, or we have been able to do that, because to date, we have bipartisan support for the community health center movement. And that is because we were able to pull from the data that we have and be able to provide to those who were asking the questions the information that they needed. Now, the data sources that we used were data sources that were already available to us. Now, they weren't designed to do some of what we had to do, so we had to do some proxy measures here and there, but that's what we had. And you have to start with what you have. And actually, it worked for us, obviously, because we have been able to maintain or actually exceed our appropriations over the last few years. So our data sources are the UDS, which is the Uniform Data Systems Report. This is the report that each community health center annually has to send back to the federal government, showing how many patients they served, how many visits, what the demographics are of their patients, what the payer sources are of their patients, what services they provided, how many clinical staff they have, how many providers, physicians, mid-levels they have working with them, what their budgets are, what their expenditures. So it's a very lengthy report that they have to send back, and even down to preventive services. So if you offered your preventive services, which you have to, how many prenatal visits were you able to provide? Were they in the first trimester or not? As it relates to some of the chronic diseases, where are you with your diabetic patients and your hypertensive patients? Are they under control or not? Are they getting in for their visits or not? So we did have this data from each of the centers that we were able to use and build the case with our policymakers. The other thing that we have, and I'm really excited about this, and I always get excited about it, because when I came to the community health center movement 6.5 years ago, I came in working with the Health Disparities Collaboratives, and it was on its last year or so. But that was a quality improvement effort that focused on chronic disease. So it wasn't just supposed to be about chronic disease, but it used chronic diseases as a way to ensure the movement forward with quality improvement. So I think I heard somebody talk about PDSA cycles yesterday. Yeah. So they used the IHI model and of course, did the whole model for improvement with PDSA cycles. They used Jack Wagner's chronic care model and pulled together a curriculum and faculty and an opportunity for community health centers across the nation to get together. This was one of the big efforts around community networking and community engagement. And when I say community, in this case, not your local community, but the community of community health centers. Ooh. Yeah, the community health center movement. And it allowed for them to network, and it gave an infrastructure for them to be able to network and get to know one another. And that infrastructure still exists. Someone asked last night, I think the question was, how did this happen and does it still exist? It does. Because of that Health Disparities Collaborative, we still see sharing of information across states, regions, and nationally, because they got so comfortable with that knowledge sharing and that opportunity to do that, as well as the quality improvement model. So that was a big success. And when they implemented this, they also had to share data back nationally. So there's a database that looks at diabetes, hypertension were the first two, and then they brought in cancer and a couple of other chronic diseases that they were looking at. Asthma was another, and I think depression. Those were the five. And they collected data from the centers on how they were moving the needle with their patients around being controlled or not. And I'll use diabetes as one. Whether they're being controlled with their diabetics, were they offering, and how they were doing that. So it's the process side. Were you ensuring that you offered group visits? Were you ensuring that you were doing their A1C tests when they came in? So they looked at all of that, and that had to be recorded. So some of that data was then used to tell the story about the quality care that's provided, as well as shared some light around the cost effectiveness side. And then, of course, the individual health center stories. So that still added to how we were able to affect change with our policymakers, not just the quantitative data, but the qualitative data as well. How did we get there? Continued. Well, some of the other things that helped us to get to where we are is a commitment to work collaboratively across state, regional, national, and local levels. We recognize that there's good work going on across the nation, and sometimes it's in pockets, and it may be an individual center in this state and another center in another state working on great projects, but the coming together, they realized how important and valuable it was to come together to look at some of the same questions and look at it on a state level as well as a national level. And the agreement and the commitment to working collaboratively was important. Also, the commitment to tell our story. The fact that we don't want to be the best kept secret. And sometimes when you're actually providing the services, especially for staff, they're caught up in doing their job. So sometimes it's hard for them to step away and say, let me tell my story. And so we came up with ways that enabled them through grassroots advocacy to be able to tell the story, not only as a patient, but as staff and others, to be a true advocate for your community health center wherever you work, whether it was at the front desk or whether you were a physician or a nurse practitioner or where you worked within the system, to be able to be an advocate for your community health center. And then the recognition of the importance of research and data to telling that story. The fact that we really had to document it and document it with data and research projects that were important to questions that we have, not questions that others have, but questions that we have was important. And the last thing is recognition that the right partnerships with academia and other partners is key to success. And those other partners are like our departments of public health in the states, as well as academics. Then there's some non-traditional partners. There's some private businesses that have become partners with community health centers around data and research and proving the case. Commitment by health centers within their capacity and interest to engage in research. I'll share a little bit in a second about the results of our survey on interest in conducting research. But our centers individually have to look at where they are and their capacity to conduct research at what level, or participate in, be a part of research at whatever level. Research looking at health services, like how are we providing this care, as well as outcomes research, what's happening with our patient demographic as it relates to some of the health indicators. And our centers have been very committed to looking at where they are in this whole spectrum of conducting research and their interests. We're seeing the interests increase across the nation with conducting research. And then some of the types of research would be comparative effectiveness, translational and dissemination research, as well as clinical outcomes research. And then at the national and state, we're seeing it more at the state, or grow at the state and regional levels, but definitely at the national level, this commitment to assisting community health centers, or facilitating for community health centers, building that capacity to conduct research within their settings. So that there is an interest, that you have a group that there's an interest and they have the capacity, so they're gone. And they're helping others, but they're on the road, they're moving forward. Then you have some who are interested, but haven't really felt out their capacity for it. And so building an infrastructure that would support it within their organizations is where they are, or even exploring it. So on the national level, and then also within my state, which is how Michelle and I guess, got to be so close, and she asked me to work on some national projects with her, because I have that interest within the state to set up a network like that within our state to ensure that health centers are able to conduct research at whatever level they want to. But on the national level, we've worked together to look at how do we do that? How do we build the networks, or work with them to build the networks of academic and community health center partnerships? How do we build the skill set on both sides? Because that skill set needs to be bidirectional. Sometimes people forget that you have to educate the academic partners as much as them sharing their research skills. You have to share with them the community health center skills, and then the time that it takes to build that capacity, that relationship. So what we did on a national level was to assess health center research activities and needs through a national survey. And we were fortunate in the state of South Carolina to be a key part of this, because we were at the same time devising one for our state. And so Michelle and I said, why do this separately? Let's do this together. And we were able to add some items to the survey that were specific to South Carolina. And we fielded it together, and actually fielded it as a collaborative of partnership between NAC, the South Carolina Primary Healthcare Association, and the others you see listed here. The Clinical and Translational Science Institute at Children's National in Washington, D.C., as well as George Washington University in D.C. and the University of South Carolina, who is one of our key academic partners in South Carolina. And then here are the results at the bottom. You'll see that we had 386 respondents, which represented 35.3%. So I think it was kind of in line with yours, somewhere around there, response rate. 55% of the respondents indicated that the health center conducted or participated in research. And then 54% indicated that they were interested in doing more or continuing with their level of research. And I would share some more with you, but right now we're trying to get this manuscript out the door. So, but I did want to try to give you some information that paralleled what you received yesterday regarding your survey. And I know Michelle, Scott, and I have committed to talking a little more about, wow, let's look at some of the other elements, the questions that you ask in your survey, some more of the questions that we ask in our survey, and how do we compare and what does it look like? So we will be engaged, and Jennifer, I'm sure you will be involved in that as well, in a discussion of looking at how our surveys compare. But our national agenda then, or for health center policy, because you kind of want to ask me to focus on the policy piece. And so here's our national agenda, and this is pushed forward through the National Association of Community Health Centers. And that is to look at patient complexity and risk adjustment. And I've heard several times you mentioned here, we see the more complex patients. How do we actually ensure that is documented and controlled for, or depending on what the research is. But how do we look at that and show that and demonstrate that? What risk adjustment models are we going to use for that? So we're still looking at that discussion on the state side, because the other thing is, even though we all have data, we have the UDS, which wasn't built for this. We have some of the health disparities data, but we don't have a central data repository for all of our centers in the U.S. So we might be gathering other data slightly different. So we have to look at that, and we're committed to looking at how we align our data collection and also analysis. But anyway, we are looking at patient complexity. Also, documenting health center value. The previous model, which we continue to do, really focused hard on access, quality, and cost. And now we're moving towards how do we incorporate all of that together? Because we kind of looked in a lot of places where that was separate, but now looking at how do you take all of that into account at one time? And then also the comprehensiveness of our services, which gets to your discussion, your rich discussion yesterday around the enabling services and how we actually document those, and how we then, when we document it, how do we make that intertwined with the clinical data? How do we ensure that it does really inform us about clinical outcomes? Because it does. It is important. It is that whole patient management, all of those services, self-management, excuse me. How do we get that piece over here with the clinical provision of services piece to show really that it takes all of that to impact outcomes, and it's not just one piece? And so we're looking at how we do that, and what measures you use, what metrics, how do you collect it, all of that. And then also the fact that the data and what we use will inform health center growth strategy. So there is some information around the health center itself. How do you want to grow as a health center? Where do you want to grow? Who else do you need to see within your communities? And so there's data that we can use both nationally and locally and help the centers with that so that they can use it as a decision-making tool. And then support for transformation and health reform implementation. As y'all are well aware, I don't think it's any secret in the world that we're going through a very interesting discussion around healthcare reform. Yeah, and I will leave it there. You're correct. You are correct. It's at a stalemate right now. But anyway, we are going through that, and currently, how do we implement it? Because we are actually named in that law, or our model is named in that law. So how do we implement some of those provisions as we move forward? And there's going to need to be data around that and looking at it so we can monitor as we're progressing with that. And the whole transformation of healthcare delivery, that relates to us becoming, and I use that term loosely because we are and have always been patient-centered medical homes, but now there's a real push for recognition of that. So like accreditation, showing that you are a patient-centered medical home based on certain requirements and certain criteria. So the data around that and the data around the transformation principles, how are we moving that forward? So all of these are very of interest to us on our research agenda. And then the continued focus on an expanded participation in health services and outcomes research, and I've already spoken about those before. And finally, the impact of non-medical services and evidence-based practice and programs on outcomes. I'll share with you a couple of projects that we have undertaken in South Carolina. And when I say we, not all of them have been at the state level. well, I'm only going to name two, though. One was at more of the state level. The other one was actually at a local community health center level, but we were able to facilitate that project with that community health center. The one with the community health center was looking at the impact of having a farmer's market on site on some of the diabetes control with their diabetic patients. So it actually served two things, because really the practical side of it is they have access to fresh foods, and it's right there. And then the research question, though, becomes how is it impacting, proving that that actually impacts outcomes. So that's one of the projects. The other one has to do with our academic partner, the University of South Carolina. We are a part of a cancer prevention and control research network, and there are 10 of these networks throughout the country who are funded half by the National Cancer Institute and half by the Centers for Disease Control. And this is looking at translational and dissemination type research. And they're looking at what are the factors or the barriers to implementing cancer prevention and control research interventions in a community health center setting. So we're working with them around what are those barriers, and looking at when you are given a specific implementation or a specific program, what is the issue around actually implementing that within your setting? Let's say it's colorectal cancer screening, and that's one of the ones we looked at. What are the things that are keeping you from meeting those requirements that you have, or the numbers that you want to meet as it relates to colorectal cancer screening? Or if you're meeting them and exceeding them, what is it that helped to facilitate that? So that's another place that we are looking at research with implementation, dissemination, and translational research. So how does it parallel? Well, services. We provide primary health care services, preventive and primary. You do as well. Enabling services. They're in both systems. We talk about the healthcare delivery system, comprehensive, integrated services. We actually have a real push now for the integration of oral and behavioral health within the community health center setting. Or if that model doesn't necessarily work, it may be that you would have a provider from a community health center who would go to a mental health center and actually provide the services there, but still the integration of those services. And pharmacy services. So I was excited to see a pharmacy last night, because I'm actually trained as a pharmacist, so I hated that it wasn't open and I couldn't get in there and look around. But that's all right. I think I played it kind of cool. But I was chomping at the bit. But pharmacy services. And I will take a moment to talk a little bit about the pharmacy piece. Our community health centers have access to a reduced pricing system for the pharmaceuticals. So if our center actually is able to open up a pharmacy on site, then they can get the medications at a reduced price by being a covered entity of the 340B pricing program. And those funds at a reduced price, the margin from where you charge and what you actually, your cost of the drugs, it has to be used to either pass that savings along to the actual patient, meaning they get it at a reduced cost, and or back into your organization so that you can provide additional services. I heard someone last night asking about the x-ray services and if they were open to people outside of their patient population, and I think one of the centers does do that, and somebody said, oh, well, is it a moneymaker? And I totally understood what they were saying. Not that they just wanted to make money, but they saw that as an opportunity to be able to add to the base of their community health center to provide more services. So we do have that opportunity with the 340B pricing program, which is a federal program as well. Let's see where I'm. Oh, and also, as far as the delivery, not only is it comprehensive and integrated services, but patient-centered. Federal government involvement and assistance, this is probably where we're a little dissimilar, although we do still have that support in some way, but we are dissimilar here. And then our population served, very similar populations. And then are seeing the importance of having a data analysis and research agenda. The fact that we are at a place now where we have to make sure that we capitalize on the data and the research opportunities, and we capitalize on that together. So, I am a strong individualist by personal habit, inheritance, and conviction. But it is a mere matter of common sense to recognize that the state, the community, the citizens acting together can do a number of things better than if they were left to individual action. So with that, that ends my presentation to you.